Welcome to Glioblastoma AKA GBM, a podcast brought to you by the Glioblastoma Research Organization, highlighting stories of GBM warriors, caregivers, medical advisors, and more. Welcome to Season 3 of our podcast, where we delve deep into the world of glioblastoma, also known as GBM. Join us as we navigate the complexities of glioblastoma with expert insights and heartfelt narratives. Please remember that the information presented in this podcast is for educational and informational purposes only. It is not intended to treat, diagnose, or prevent any disease, and you should contact your medical provider or healthcare team with any questions. Novocure is pleased to support the Glioblastoma AKA GBM podcast. Novocure strives to extend survival in some of the most aggressive forms of cancer through the development and commercialization of their innovative therapy called Tumor treating fields. Novocure partners with the Glioblastoma Research Organization to work together on behalf of patients and their loved ones impacted by GBM. To learn more, visit novocure.com. Dr. Ashish Shah, welcome to the Glioblastoma AKA GBM podcast. I'm so excited to have you here today to talk about your experience as a neurosurgeon and your background. So thanks for joining the party.
Yeah, no, thank you for having me. I'm glad to be here.
I would love to hear, for everyone that doesn't know you, I'd love for them to hear more about your background and how you got into neurosurgery and kind of like what got you here today.
Yeah, I'm Indian American. My parents came here kind of like every Indian American family came in the 1980s to Texas. I grew up in South Texas, Corpus Christi, a very small city in South Texas. And I spent my whole life there until applying to college. And at the time, there's all these kind of what we call baby doc programs. I don't know if you've heard of them, but basically they're these accelerated programs to go to undergrad and medical school kind of at this in a shortened course. And I was applying across, the entire kind of spectrum. And, the places that stood out were one in Boston, another one was in Miami. And they're 7 years. You get your degree in 7 years. And in Miami, it was like a nice 75 degrees on January. And then in Boston, it was negative 10 degrees. So I ended up here. And I haven't left, since the last 16 years I've been here. I love Miami now. I'm like a kind of quadruple cane. I did my undergrad, medical school, and residency, did a fellowship here as well. And then I left for a year to the NIH just to kind of work on translational work at brain tumors. But yeah, no, Miami's home now. So
that's amazing. And like, what got you into wanting to be a neurosurgeon?
Yeah.
How does that even spark?
It's a little bit of a long story. So kind of when I was in undergrad, I was really interested in global health. And, for me, being in Miami in a kind of thriving international community, I really wanted to be involved and kind of use my knowledge and kind of help out other people who are less fortunate. And the idea of helping out in the Caribbean was a big deal to me. At the time, Haiti was, a country that really needed a lot of support, and we're so close by. And there was an organization on campus, medical campus, called Project Mentorship that kind of helped out in Haiti. And so at the time, I went on a trip with them to kind of take vital signs. I didn't know what I was doing, but I knew how to kind of take blood pressure and pulse. And I said, okay, maybe I can help out a little bit. And so our fraternity got involved with this organization. And I met the chairman, Barth Green, there at the time. And he's, the chairman of neurosurgery, founded this organization, was going down to rural Haiti to give, anti-parasitic medications to, people and blood pressure medication. I was like, what is this guy doing here? And then I kind of started figuring out, oh, wow, he's amazing. He started the Miami Project. He's doing Philanthropy in Haiti, and he's a chairman of neurosurgery. I said, I want to be like this guy, who's, really changing the face of humanity. And so I started following him around, shadowing him, and I love neurosurgery. But he did spine surgery primarily. But the moment I got into the brain surgery rooms, that's kind of where I really got very interested. And so the rest is history. I started following him around, and then neurosurgery became a passion of mine. Spent every day in the operating room as a medical student, and I loved every minute of it.
That's amazing. I feel like people, particularly like the neurosurgeons that I've met, every single time it's like, I knew I wanted to be a neurosurgeon from a young age. And it's like, that's incredible to have that much like decisiveness. I'm like, yeah. I can't fathom that, but that's like amazing.
Yeah, most people kind of know. I knew I wanted to do neurosurgery more than I knew I wanted to be a doctor.
Okay.
If that makes any sense. Because at the time I was
kind of. Let's elaborate.
yeah, well, I mean, I'm in high school, if you can imagine, and I'm making a decision to go do a baby doc program. So I don't really know much about medicine. I kind of know because, my brother was doing something similar and a lot of people in my family were doing something similar. So it was an easy decision to make.
Mm-hmm.
You have good scores. You can try to get a medical school. You have a direct admission program. This is easy decision. But then really kind of figuring out what kind of doctor you want to be, you didn't really know. And then when I found neurosurgery, that was a huge passion of mine. So I was more driven at that point in my life to do neurosurgery than I was necessarily to be a doctor, because being a doctor was the easy path, but picking neurosurgery was a difficult one. In Haiti, there's a proverb that's it's called mountains beyond mountains, and that's kind of for me, that's how neurosurgery is. It's every single time there's an obstacle, and you have to get yourself better to overcome it, and then beyond that, it's another obstacle. And so it's always this kind of push and pull to try to make yourself, the next best version of yourself. And neurosurgery kind of did that for me. And same thing with the research kind of. And so that was kind of a thing that kind of motivated me in that sense, if that makes any sense.
It does. Were you ever worried that you wouldn't match? Because especially since you had neurosurgery in your head from such a young age, not just I want to be a doctor. I think, people that I know that have gotten into medicine will, you pick neurosurgery 1, GP number 2, I don't know.
Yeah.
Gastroenterologist number 3. I mean, there's people typically have options, but in your mind, you're I'm going to be a neurosurgeon. What was that like for you, matching process? So I was lucky. I had 2 big people kind of in my corner that I really kind of, were my mentors. One was the chairman of neurosurgery at the time. And then also, Dr. Komatar, who was a mentor at the time as well for me as medical school. And so it was very important to kind of have them in your corner. And I knew it was going to be competitive. When I was a first year medical student, I said, I want to do neurosurgery. And the guy goes, well, if you want to do neurosurgery, you had to be number 1 in your class. You have to have at the time is we took step 1 very seriously. And he's like, you have to have above a 270 on your step 1, which is basically, getting every single question right. Mm-hmm. And you have to be AOA, which is a medical honor society, and X, Y, and Z. And you had to publish all these papers. I said, at the time, I'm like, oh man, I was like, this is going to be tough. I was like, I already know I didn't do that well on some tests. And, so I was like, I don't know if I'm going to be able to do it. But, I just said, okay, I'm just going to persevere and kind of make it happen. And so, that thought kind of came through my mind, if I wasn't able to do it and kind of what my backup plan would be. Luckily, I had enough support of the department that I kind of had some reassurance that I was going to be able to match. But the other thing a lot of people don't talk about is, at the time I was engaged to my wife, and she was also in medicine. So I said, well, how do you work that out? She wanted to do pediatrics, and I wanted to do neurosurgery. So there's something called a couples match. I don't know if you're familiar with this, but essentially you basically decide on cities and programs together. The problem is if someone else doesn't match, then you may not match. Right. So it's kind of this romantic, and it worked out.
It worked out.
And you're married. And you have kids.
We're still here. Yeah.
What do your kids show any signs of wanting to be in medicine?
Yeah, my son is very interested in medicine, and he's like, oh, Papa, you're a head doctor, and Mama, you take care of kids, and he's like, I'm going to be everything. And I said, okay. They do see the passion that you bring to work, and I think they do try to model a little bit of that. And what's fun is that you do, I was listening to someone tell me this is really not trying to think that your work is painful. You want to make your work enjoyable so your kids can see that. And so I think that's something that I try to remember, coming home. Even if you had a bad day at work, it's good to, to model that behavior, because, if you're enjoying your work, they're also going to see that as well. And so that's something I've learned, I think, in the last year or so. So
what's it like for you working directly with Dr. Komatar? You mentioned that he's your mentor, and I didn't even know that. And so you guys are in the OR together, and you guys are on the same team now. How was that?
No, it's great. I mean, he's definitely a mentor for me. So the story for us is he actually came to Miami from Sloan Kettering when I was a second year medical student. And so before he even came, Dr. Green connected us together, and he said, oh, hey, by the way, I have this star student. He's interested in brain tumor research. I know you're getting hired here. Maybe he can help you out. So, it was his first day coming in. He had a grand rounds kind of meeting, and he said, oh, Ashish, let's go get some Subway. So we had Subway for breakfast, which I think is unusual. I don't know. No one ever has Subway for breakfast. And so we talked about brain tumors and creating a brain tumor bank and infrastructure. And this was, 2012. So, this is, nothing was set up, in the sense of infrastructure. And so we got a clinical research coordinator at the time and started working with people. We started getting a medical students to work on, different clinical research projects. And then really at that point in time, the infrastructure started building. We found people who wanted to do brain tumor research. And I think it was at that time that, there was really that kind of igniting flame started. And then, the rest of history, we've been working together for, over 12 years now. And now we have a Brain Tumor Institute.
Let's hear more about that. I know.
Yeah.
Is it public knowledge yet?
Not sure the press release has been out yet.
Okay. I'll wait.
But it has been approved.
I'll wait to publish this until the press release is out. But I'd love to, if you can share more about the new Brain Tumor Institute that's happening now.
Sure.
I think it's out yet. Well, anyways, I'll wait to make sure this is published by the time. But breaking news, everyone.
No, it's great. I think, in order to have an institute designation at the university, you have to have a lot of infrastructure and you have to have, the right amount of basic science, translational research and clinical kind of enterprise. And so it was a big undertaking for the university to kind of invest in that. Antonio Ivarone came down from Colombia and, with Macarena Del Fuente, who's the head of our neuro-oncology, and Dr. Komatar, who's the surgical neuro-oncology, kind of, all together kind of put together this proposal with all of us supporting it to create this Brain Tumor Institute. And the idea is, and the mission is still the same, but the idea is now we're putting even more of an emphasis on translational research, on making sure that we are all collaborating together on the same thing. And, the idea is that we bring in, people from outside to kind of bolster this team mission. And the Institute, it really helps define that, I think.
If someone comes to see you as a practitioner, like what can they expect? What is a normal process at Sylvester? Like I know you guys have obviously neurosurgery, you have neuro-oncology, which is incredible because not a ton of hospitals do have like a specialized neuro-oncology department. Like what does it look like as a patient in the process to come see you and your team?
So the important thing is, and a lot of people are scared of going to academic medical centers because they think the wait times are long. It's hard to get, just seen quickly, and it's hard to navigate all the different departments. And I think something that defines UM separately is that you're able to see, our team within a week, within almost, 24, 48 hours, of an appointment to kind of get seen quickly. And then to get seated with the neuro-oncologist, radiation oncologist is also very similar. So a lot of times the medical neuro-oncologists, their office is just across the street. So we call them and say, hey, by the way, this patient's here. Do you mind seeing them at the same time if possible? And so they actually have the same visit the same day. You see the medical neuro-oncologist, radiation oncologist, and the neurosurgeon within the same day, usually sometimes, at most within the same week. And so you have that kind of comprehensive care to get everybody kind of seen at the same time. It's expedited. And then, after surgery, when we look at the pathology and talk about everything, we have the comprehensive tumor board where everybody discusses and gives their input. But, the most important thing is the care is expedited and you're kind of stratified with clinical trials on the same time, the same visit. Does
that mean when you're saying like a tumor board, for anyone that's listening that doesn't understand, like talk more about that?
So the tumor board is basically, you have neuropathology, the radiation oncologists, the ones who give the radiation, the medical neuro-oncologists who prescribe chemotherapy or the immunotherapy, and the neurosurgeons. And then you have the nurses who are on the clinical trials. They're all kind of in the same meeting. And we discuss everything under the sun in terms of how did the surgery go? What did the pathology look like? What are the social factors going on with the patient? Do we need to work on insurance? Do we need to work on, supportive care? And so all these things are discussed for individual patient basis. What's the genetic profile of the tumor? Will this tumor respond to certain molecular inhibitors that are not, standard of care? And so we kind of go through all the different options. And then it's just not just one time. So sometimes, even after surgery, say something changes longer, we bring the patient's case back up in the tumor board and we discuss, okay, well, what do you think about these changes? We bring the radiologist involved. So I look at all the slices and say, okay, well, I think this is just treatment changes from the radiation, or this is maybe an immune response, or maybe this is the tumor recurring. And so that kind of gives us a better idea. We have a consensus decision with all the practitioners, and it really helps stratify care. So the tumor board is a really important part of our days, and all of us block that time off to make sure that we're fully.
And
100%.
This happens daily.
Once a week. Amazing.
Yeah. And that's so cool. I think, again, like not a lot of institutions, I feel like will do this I think it's great that they're all the departments that kind of like get together to make a comprehensive plan for the patient. Like, what, in your opinion, how does that help the patient versus, let's say a patient goes to XYZ place for surgery and then goes to XYZ place for radiation, or I don't know, maybe another place for chemo. Like, how does it benefit having all of your providers in one place?
I think there's a huge part of it is also, there's like such a fragmentation in medicine with, where's the charts, where's the pathology report, where's the tissue when you want to get next generation sequencing, which is basically, kind of like, deep mutational profiling of the tumor. How do you know where that sample is? If you go to another institution, you get surgery somewhere else, the delay in getting that tissue and getting that sequencing done, can affect, how fast you get treated. The other benefit is that, you get multiple opinions about your case. For example, if surgery, you have multiple surgeons on the phone. So for example, if someone does surgery and takes out, X, Y, and Z tumor, you can look at it and say, hey, this looks good. Or, if a tumor comes back and it's in an area that you can resect, certain surgeons may be more comfortable resecting a certain tumor. So it's nice to have a consensus opinion on that. It's also nice to have multiple neuro-oncologists involved so they can decide, whether or not this is the right treatment design. There's all these new targeted inhibitors now on the market. And a lot of times if you're at a non-tertiary care center or like a non-comprehensive cancer center, maybe they don't know about these inhibitors. Maybe they don't know about new trials that are showing promise. So it's really beneficial to be in this kind of center, and I think the data has shown it. If we looked at this, a couple of years ago, that patients who are in these tertiary care centers tend to have a better outcome than if you get seen kind of in a fragmented way. So.
And what happens like in these meetings? Let's say like a neuro-oncologist. Let's say there's 3 neuro-oncologists and 2 think that one course of treatment is best for the patient, and then doctor number 3 is like, no.
Right.
How do you guys deal with that?
Yeah, it can be uncomfortable. Usually there is the main treating neuro-oncologist who's seen that patient in person and kind of knows and can drive that decision. And if there's a difference in opinion, a lot of times we'll kind of ask around, and at the end there is usually I would say 99% of the time everybody decides on something together and there's a consensus on the treatment. So I would say that where we have a lot of difference in opinion doesn't really happen often, but if it does, then I think we all kind of chime in, and then that just kind of drives the decision in a certain way.
Okay, good to know. And talking about your work, I know you're not only a neurosurgeon, but you also do work in research. So I would love for you to share more about maybe like what you're working on, what is upcoming for you, and what your lab is doing in particular. Yeah,
sure. So as this goes back to the mountains beyond mountains. The idea is that, even despite our best surgeries and, no matter how perfect our scans look, the outcomes for the disease haven't changed much over the last 25 years. And for me, that's unacceptable as someone who's trained such a long time, and knowing that I'm doing this for my life, and I want to leave, I want to be able to improve my outcomes for my patients, And and so the lab for me is the best way to kind of do that. I can study a problem that I've seen in my patients, and I can bring that to the lab. And so our lab focuses on viruses and cancer. So it's a glioma kind of virology lab, and we do the whole spectrum of what I call retrovirology in gliomas. One is that we look at retroviruses that may cause gliomas. And on the other side, we look at ways that we can improve the immune response by using retroviruses against gliomas. So it's kind of it's 2 sides of a coin. The most important thing we found recently was that we found an ancient, kind of 6 million year old retrovirus that's in our genomes.
I saw that was in the news. First of all, we're going to pause. Explain how that even happens. How do you find a 6 million year old retrovirus?
Yeah, this is.
And how do you even say like this is 6 million years old? Like, how does that even happen?
That's a great question.
So many questions.
It is. So a lot of people don't know this, but 8% of our human genome is made of retroviruses. And what that means is that during evolution, sometime when we were old world monkeys, kind of going into humans, we got a similar to HIV, but a similar kind of germline infection in our genome that's now kind of it inserts itself. Retroviruses have a UA that they infect us, and then they insert their genome into our body. And if it goes into your germline, then basically what that means is that every single cell has that sequence. Now our bodies are, they don't find a use for these retroviruses. So they basically mutate these elements because these elements start moving around and it gets mutated, over millions of years to the point where they don't become functional. In this particular sequence, this retrovirus actually exists like full length, sequences in our genome. But our bodies find a way to suppress this by, epigenetics. They basically, put these different methylation marks on them and basically suppress them from actually producing viruses. In cancers, they lose this suppression mechanism, and it actually becomes, and it contributes to what we call stemness. Interestingly, our body actually has I would say almost a natural use for these retroviruses, because in the placenta, whenever the baby's forming in embryogenesis, you can actually find retroviral particles being emitted from the fetus, and that kind of contributes to what what we call pluripotency, so their ability to kind of remain stem-like. And then, of course, as we get older, we lose that, and so this, in normal tissues, it doesn't really get expressed much. But we found in glioblastoma, actually, there's certain areas that express this protein significantly. And the very cool thing is that these are retroviruses, and we have drugs that are called antiretroviral drugs, and so we can actually use them to actually inhibit the expression of these sequences and reduce the cancer burden. So we're actually working on a clinical trial, kind of doing that right now.
That's wild. Like, that is so cool. Well, congrats on the development of the work. Can you talk more about so where is the idea of the trial right now? Are you guys recruiting patients? Are you not recruiting yet? And what does a timeline look like? And how would the research actually be developed for a project like this?
Yeah. So, first thing, the first thing we found was that, these antiretroviral drugs, can affect this virus expression in the gliomas. And we said, okay, well, does that affect the cells living? And actually, this drug actually kills the cells too. In fact, and they just looked at this in colorectal cancer, and they found that it actually had a 40% clinical benefit rate in patients who had no benefit with chemotherapy. And so we said, okay, well, can we design a trial that doesn't give up standard of care for gliomas? So we took patients who were going to have the most difficult to treat patients, the patients who are unresectable gliomas, and we said, okay, well, can we really help these patients out? So right now, what we do is we do something called a laser ablation to kind of kill the tumor a little bit, and then we. And
what is laser ablation for anyone that's listening that doesn't know?
Yeah, sure. Sorry, I know it's a lot of. So laser ablation is a kind of a minimally invasive procedure that we've developed. We haven't developed it, but we kind of used it on difficult to access brain tumors, specifically areas that normally you wouldn't want to go in and take out. You can actually put a minimally invasive cannula into the tumor. You can take a biopsy, and then you basically use heat to kill the tumor. The benefit of this is it kills the tumor cells. And two, it also opens up the blood-brain barrier and kind of what we call potentiates the immune response. And you can do this in MRI suite, and you can actually see how hot the brain tumor is getting and protect critical areas. So it's very nice. It's minimally invasive. And
when you say how hot the tumor is getting, what does that mean?
So if you imagine where a laser kind of heats up tissue, you put the laser in the tumor, and it heats it up at a certain wavelength. It emits energy into the tumor to heat it up. When it heats up beyond a certain degree Celsius, go about 40 to 50 degrees Celsius, you really get a lot of tumors, a lot of cell death. And you don't want to have too much of this because it can affect normal brain tissue as well. So in the MRI suite, you could actually look at the temperature in the brain and protect the areas to make sure that this area of the brain doesn't get beyond a certain temperature. And this is kind of validated by two major systems that are out there right now. One's called the Visualase, the other one's called is Monteris, and they have these excellent platform to kind of delineate the brain tumor and figure out the target temperatures in the area.
Quick interruption question.
Go ahead.
Someone that's listening to this might be like, "Oh, he's saying that heat can kill tumor cells." So someone might think, "Oh, if I spend a lot of time in the sauna." Is there any study or data related to that has anything to do with someone that currently has a brain tumor? Because I know that question will come up just by hearing it, because that came up in my mind.
Sure, absolutely. So this laser ablation is actually giving the heat within the tumor itself, and not in the rest of the body. We're warm blooded, so our bodies have a very good way of temperature regulation. So if you spend a lot of time in the sun, that doesn't bring the temperatures in your brain up to a degree that it's going to kill the tumor cells. In fact, if the rest of your brain goes and has temperatures, above, 104 degrees Fahrenheit, it's not going to be, you'll probably have a febrile seizure. So I do not recommend that. But if you are, using this system, you're able to give what we call like a local delivery of hyperthermia, if that makes sense. It's safe and efficacious.
Okay. So then going back to talking about the process with laser ablation and then the rest of the project.
Yeah.
You can continue.
So, of course. So, we are, kind of we're treating patients with unresectable glioblastoma who undergo something called laser ablation and chemo and standard of care. And we're adding on top of that these antiretrovirals. And we're adding 3 different antiretrovirals because we know these retroviruses they have differential sensitivity. And so the idea is that, by adding these antiretroviral drugs on, we're able to, one, eliminate the treatment-resistant cells. So, the chemotherapy and radiation affect the proliferating cells, and you have these cells that kind of sit around in the glioma that they don't respond to radiation, they don't respond to chemotherapy, and then those are the cells that recur, and they kind of are responsible for what we call the tumor heterogeneity, meaning the tumors can be different types of cells. And so we're hoping to target this by using the antiretrovirals. The good news is they're FDA approved. We know their safety profile because they've already treated it with HIV, patients with HIV for several years, and they penetrate the blood-brain barrier. And so we designed this trial to kind of target this with the laser ablation too. We also noticed that the immune cells after laser ablation come in quite robustly. So it's kind of using the laser ablation to kind of potentiate the immune system, and then using the retrovirals to kind of go in there when the blood-brain barrier is open to kind of kill the stem cells.
Why do you think that this hasn't been done before?
That's a good question. So I think that the finding was we recently developed this finding with the fact that this antiretrovirus is expressed in gliomas, and that one hasn't been done before. So knowing this link hasn't necessarily been done. There are some trials that were done using antiretroviral medications against gliomas, but not the same class, if that makes sense. So these ones were known not to target this retrovirus specifically. They target other off-target effects. And so we're using medications that are targeting this retrovirus, and we're optimistic.
What are you most excited for, being that you've been doing this for about 16 years and you have this new trial developed? Are you most excited for the upcoming development of new trials, or are there any, AI tools that you're using in surgery, or just what do you feel is changing in the field that you're most looking forward to?
I mean, as a neurosurgeon, I think, the things that really have changed the field are the fact that we're able to access the tumors every day. We see the brain, we see the tumors, and we know the difficulties in treating these patients. We know when we can't operate on certain patients. And so having the tools to go in, whether it be laser ablation, whether we deliver viruses into the tumor itself. We have another trial we're starting actually to deliver retroviruses into the tumor, or whether it be to kind of potentiate the immune response locally. We have access to that every day. And so in my opinion, using our tools to deliver these therapeutics into the brain itself is the thing I'm most excited about. And so right now in the lab, we're working on a lot of things to basically, really, harness the immune system, but do it locally, because a lot of the failures in all these clinical trials is that you're giving, something IV, or you're giving something oral, and it doesn't really get to the areas where it needs to get to, or the toxicity of the drug's too high. So, I think that's, to me, the most exciting part is being able to really, rev up the immune response, and deliver these therapeutics into the brain itself.
Mm-hmm. It's always nice to see neurosurgeons. I don't think I've ever met a neurosurgeon that's not passionate about neurosurgery, but it's nice to see that the field that you choose to do as a living, it's you're not just I'm a doctor, it's that you actually care about that. And so on that topic, what is something that you feel you always tell your patients, or what is something that you always like people to know about? Let's say someone just got diagnosed with GBM and they come see you, what do you tell them?
Yeah, that's a very difficult conversation, that we have. And the first thing I tell them is, we got the pathology results back, and you give the news about glioblastoma. The first thing they want to do is they want to Google and say, glioblastoma, what happens? The first thing you read is poor, incurable brain tumor, poor outcomes, bad survival, right? And I try to tell them this is a process, that we're in this together. We're not, my relationship with you does not go away. So when we when we embark on this journey together, this is a stepwise approach. And so surgery is just the first part of it. Then you start the chemotherapy and the radiation and the clinical trials, and every single part of that way we're with you. And so we're not, the MRI, and I tell them every single step, we look at together. So for example, after surgery, the tumor is out, right? But we still have to go through the chemotherapy and radiation, and every single patient responds differently. So I kind of, you don't want to, go online and read what's, what everybody else is saying about this thing, because it can be disheartening at a time where you need hope and you need to have the courage to go to the next steps. So
how do you feel like you're able to provide hope for your patients?
Taking their tumor tissue, analyzing in a lab, finding different markers, and finding, basically, I really think that the next treatment in GBM is somewhere in these trials that are being conducted. And I'm hopeful that our trials will show result, but we've actually seen a lot of good results with, in Japan, they're using a oncolytic herpes virus in Japan that's now FDA approved for all gliomas. There's a lot of positive results that are kind of coming out now. And I think that's what I'm most hopeful for my patients is. I'm hoping that, that in the next 5 to 10 years that I'm going to be able to come up with a treatment that I know is going to move the needle for my patients. And I won't give up until we do it.
Definitely. Well, Dr. Ashish Shah, thank you so much for coming on the Glioblastoma AKA GBM podcast. It is awesome to hear more about the work you're doing and the incredible research that's being developed in your laboratory. So thank you so much again. And I'm stoked for everyone to hear this. I mean, I learned a lot. It's always fun, bringing on, especially I don't know, every single person that comes on the podcast, I'm always I always learn so much more in a podcast episode than I ever did in my entire schooling career. I also didn't pay attention in school. And it's actually really funny because my parents, when I was a kid, they were like, just maybe go to college, make us happy. They didn't have very high hopes for me. And now it's doing all the nonprofit stuff. So it's funny.
But honestly, organizations like GBM Research Organization are the reason we're able to do this kind of research. And, I don't think you guys get enough thanks for everything you're doing, because it's not easy, funding the research, because a lot of people pay attention. The clinical costs are very high. You get surgery with for a brain tumor or something like that. It's very expensive. Mm-hmm. But the real movements in treatment and the movements that are going to happen because of the things that you're funding. So
yeah, I know. In the video that we did with Britton King, who's the director of Foundation Relations or Philanthropy. Yeah. I'm sorry, Britton, if you're watching this, if I'm watching it. She's awesome. But she was talking about the importance of private philanthropy, and people need to understand that a lot of, especially for you guys as researchers, one, you're also seeing patients and you're operating on cases. And so your entire day is not spent grant writing. And then so you're in the operating room and then you're seeing patients. And then if there is any time left at the end of the day, you guys are applying for grants, which is also super challenging. And then that takes months to come into. Yeah. So I know that's private philanthropy. It really helps you guys in the work that you do.
It makes huge difference in the laboratory research. We've been grateful to have, charitable organizations donate to our lab, and the outcomes that we've had in the lab because of that are immense. Applying for a grant takes about a year to get funding in, versus private philanthropy goes immediately. Mm-hmm. And so, the amount of translational tools, and we have about 3 or 4 projects that are hopefully going to phase 0 trials in the next few years, and a lot of those are due to philanthropy.
Well, we are honored to support the work that you guys are doing. I know we have an upcoming project to talk about as well.
Absolutely.
But thank you for all the work that you do and for the support that you provide, and hope that you provide to patients. So it's always a pleasure to hang and to chat, and honor to have you on the show. So thanks for having me. Thanks for stopping by.
Appreciate it.
Thank you for tuning in to another episode of Glioblastoma AKA GBM. To learn more about the Glioblastoma Research Organization, you can visit us online at gbmresearch.org, on Instagram or Facebook at Glioblastoma Research, on Twitter at Glioblastoma.org, or on LinkedIn as Glioblastoma Research Organization. To start your own fundraiser, to donate, or to learn how to get more involved with the organization, please email us at contact@gbmresearch.org, and we'll see you on the next episode of Glioblastoma AKA GBM.